Welcome to Make America Healthy Again. Join Dr. Charles Antinori and friends as they share solutions, tips, and insights that only doctors know for creating better health. Here's Dr. Antinori.
This is the first one, so I guess I should introduce myself. Just semi-retired after 50 years of surgery. I'm doing this and still doing wound care, so I'm still doing a little bit of surgery, but just a couple of days a week. I went to Regis High School in Manhattan, where Dr. Fauci went 8 years after him, and then Cornell, Dartmouth Medical School for 2 years, Harvard Medical School, trained at Columbia, and then down in Texas with Dr. DeBakey. And then I've been in South Jersey for the rest of my life, doing surgery in several different hospitals. And I just semi-retired about 2 years ago. So I did cardiac surgery. I was a thoracic surgeon, but I also did a lot of general surgery, a lot of chest-type thoracic surgery, as well as heart surgery. But I haven't done heart surgery really since about 2004, when I left Cooper in South Jersey. So anyway, we start like we said.
Sure. You want me to introduce myself? I'm Vincent Grasso. I'm a physician based here in New York and New Jersey. I did my medical school at Des Moines University in the School of Osteopathic Medicine out there. And I did my surgical training at Mount Sinai in New York City and a fellowship at Yale University in advanced minimally invasive surgery. I have a strong technology and business background. I have an MBA in finance and business process engineering and a master's in information system. And I've been working in AI for a long time, over 20 years, building applications and platforms and using it before it became very popular as it has over the past, say, 5 years. It's a very exciting time for all of us involved in bringing AI into the mainstream in healthcare.
You have your podcast on AI too, right?
Yeah, we have an exciting journal. We were,
Right.
It was a great pleasure having you as a guest. And the journal is Artificial Intelligence Surgery, launched by a dear friend in 2021, Dr. Andrew Gums, a triple Yale surgeon, interesting guy. And we just got, Charlie, our impact factor of 3.6 about 2 weeks ago, which is astounding for a 4-year-old journal. So we're very excited about that and looking forward to getting you back on as a follow-up to the original podcast that you undertook with us.
Yeah, anytime. I'm really, compared to how it was when I'm still busy, surprisingly, but I don't know how I fit in like the 60, 70 hours a week of work and everything else I do. I guess I've gotten like less efficient. I am spending more time with the grandkids. I got to say that.
Good for you.
Yeah, two little girls, and Alessa's pregnant again, so we made it supposedly a boy. They have blood tests now. You can get it 10 weeks and tells you what they are. It's unbelievable. Yeah.
Charlie Jr.
Yeah, but maybe I don't think so. Maybe Paul Jr. We'll see. Anyway, you were talking about how it could bring down the cost of medical care too. One of the things you want to say?
The AI ecosystem, if you think of it as an ecosystem, has several pillars. One of the pillars is conversational computing. So if you talk to a chatbot or an avatar, if you dial an airline and you're engaging with some entity to book an appointment, book a schedule, book a flight, that's all conversational based. The second pillar is all the back end things like machine learning, computer vision, all that stuff that requires analyzing data and training algorithms. And the third leg of the stool, so to speak, is what we now see as agentic AI. It's all process driven. It's all things that are triggered based on information coming in to execute. So the cost of labor, as it's impacted by AI, involves the dance of all those three elements. For example, if you dialed Cooper Medical Center and a human answers the phone and you said, "Can you tell me when Dr. Antinori has office hours?" And they looked up something, they said, "Oh, Monday, Tuesdays, 2 to 5 p.m. So they hang up. Okay, well, there's a cost to that. There's the hourly wage of the worker divided by the time they spoke. So it's a number. Maybe it's $1, maybe it's 80 cents. There's the benefits for that employee. There's things. If the AI answered the phone and was able to intelligently tell you that information, that would be at a discounted price. Now, we don't want to fire people. It's not about firing people so the machines replace them. That human being that told us 2 to 5 Monday and Tuesday he's available, their minds are better served answering more complex questions, right? So humans shouldn't be answering simple questions like, when are you open tomorrow, your hours of operation.
Right.
They should really be working at more complex level questions to justify the value they can deliver. So in a call center, there's an enormous amounts of savings offered by having conversational computing integrated into it. That's just one example.
Right. It is really interesting how this has just jumped on the scene in the last couple of years. I mean, when we did the podcast just maybe 2 years ago, something like that, 2 or 3 years ago, and now all of a sudden, all you hear about is AI. And then what I've been hearing about the most in the last 6 months is how much power it's going to eat, and how places are like, Microsoft and these guys are like they want to build their own little nuclear power plants to run their AI.
Yeah. As the large language models, as more computational intense applications go live in a data center, you have to use a lot of processors, a lot of memory. There's a consumption of resources. The more people engage, if you have 1 million people tomorrow engaging with ChatGPT, those data centers need to scale up, and they're energy intense applications. So there's going to be this shift to a different form of energy, like microreactors. So this is an interesting time for energy consumption and costs.
Yeah.
In New Jersey, I think the electric bills are going to go up 20%, or there's some they're in a ride
already. They were sold on the wind and solar, but the beach people, no joke. I mean, it was last winter, not this winter. All of a sudden, whales were just coming up on the beach, and dolphins, and I think that pretty much put the kibosh to the wind out, and at least on this part of the country. But apparently, the forces that are trying to put these wind things in are very powerful. So I'm not sure it's completely dead. But that's the problem. You can't run AI or something like that on wind and solar. You got to have something that's continuous.
It's power. Yeah, there's orders of magnitude of requirements for energy, and the AI folks, the data centers are going to get it first, no matter what. That's just going to happen.
Yeah. That's
a good point. But this is an exciting conversation because it bounces around between, the use of AI in a call center, the power requirements, how to decrease the cost of labor. You're hitting on so many good points that, your excellent book. It was exciting that I went through that and knowing you and seeing where AI can bring a lot of value to your initiative, to your passion for making America healthy again.
Right. Really. Do you think it's going to replace like family doctors at all? You think? Let me say it another way. I was talking to a cardiologist that I've known for my whole career, and at Elmer, and he was saying his kid became a financial analyst, and I say a financial advisor, and I said, "Oh, that's great. That's when it's good business right now." And he goes, "Yeah," but he goes, he's really afraid they're going to get replaced completely by AI. And I just wonder, you think, well, actually, family practitioners are almost already getting replaced by nurse practitioners already. The way that's going. But will the nurse practitioners get replaced by AI then?
Well, I stopped doing surgery like you a while ago, and I keep my license active. I was doing some part-time adult medicine in a friend's multi-specialty clinic, and I did some time in motion studies even in December because I can type really fast and I can see 25 people in a day if I wanted to. And I realized that out of that 15-20 minute slot, I was spending about 10 minutes trying to look up information, asking the medical assistants, I'm still waiting for the x-ray report, fetch me this, get me that. And I wasn't spending all my time using my brain and training to solve more complex problems.
Right.
That stuff, all that stuff goes away when you have an information system that's managed well, where, the day before you would fetch all that stuff. It would be ready for me to review. I wouldn't have to be asking, where's the consent form that's supposed to be here?
Right.
Think about all that churn that you do. It consumes a big part of that patient encounter. And that's a big waste of time, right, for a clinician.
Absolutely. Well, in the book, I talked about it. I looked up, there's been a lot of papers published on it, especially when, around 2014, when it became mandated to do computers. You pretty much had to put a computer in your office. And the general thing is mostly done on internists and family practitioners, but they ended up spending, once they put the computers in the office, it's about 50% of your time on the computer, typing things in, looking things up and stuff like that. 25% of the time with your patients, and 25% of the time doing other stuff, the phone calls,
right.
this, that, the other, the paperwork, all the stuff you have to sign. When you come to the office, there's always a pile of stuff. If we were lawyers, I would probably spend some time, signing that and get paid for that time. But we just sign things, generally speaking, without even looking at them.
Yeah, so that's the a big cause of physician burnout and nurse practitioner burnout is all this mindless clerical stuff. I mean, it's not mindless that it's mindless, but it's not what we should be doing. We're supposed to be using, that time in solving complex problems for our patients, and that can be very readily addressed with a well-managed platform that uses pieces of the AI ecosystem intelligently. So that's a no-brainer for me.
Yeah, the other thing that they talk about with the computer and especially with burnout, you reminded me with burnout, and they talk about it in the book too, that most doctors spend about 2 hours after they see the last patient doing computer work, paperwork, et cetera, all of that. And a lot of times that runs into dinner time. And, a lot of the doctors will then go home so they can eat dinner with their family. But then after dinner, they got to get back on the computer. You can't really leave it till the next day. I hate even getting more than like 2 or 3 patients behind in my computing. It's like,
that's right.
I'm afraid if I get more than like 2 patients behind, I'm afraid I'm going to forget some little detail that I thought was pretty important to, when I enter it. Sometimes you want to see the patients so they can be moved out. The nurses can do their dressings and things like that. So you let yourself get behind in the computing. But
well, I'll tell you, I've written programs for different kinds of customers, insurance companies, et cetera. And I will tell you, the insurance companies know when your notes are not done on the same day, because the longer there's the delta between the date of service and your note, the more generic the note sounds,
right?
Because you can't remember the details. So the machine, when they analyze your progress notes, they know when you're not really doing it on the day of service,
right?
And they also can ingest like a echocardiogram report that may report that you have severe aortic stenosis, and then in your auscultation exam it says normal, normal rate of rhythm, no murmurs, right? So. Really? Okay. So severe aortic stenosis, you can't hear with a stethoscope.
Yeah.
So this isn't even complex AI. This is basic data analytics, parsing. So physicians need to get on the bandwagon, so to speak, or they'll be left behind. They won't have a seat at the table when these negotiations are taking place. I invested a lot of time in my technical side, but I have a lot of physician friends that they're kind of behind, and they're going to be told what to do. They're not going to be decision makers in their health system.
Definitely seeing that already, Vincent. Guys like you that it's becoming a whole new specialty almost, the physician administrators. And it's good, like you said, the Dr. Mazzarelli at Cooper, CEO is a physician. But you need training. You got to do an MBA or something like that. You can't just manage some big thing like this with an MD degree. You can't manage a big entity like Cooper with an MD degree.
No. You need, it's an interesting time, and physician business executives understand the complexities of healthcare.
Right.
But there's not many that go outside their comfort zone of just clinical practice and do the extra work to get an MBA. It's not, it doesn't get done in 5 minutes, and then you have to apply it. So it's an interesting time for everyone. I'm very excited for, your insights into how all these things will make America healthy. It's not just clinical, it's business and IT.
Yeah. You reminded me of one other thing, too, when you were saying how they'll know when you have a time between your dictation and the visit and everything. But when I started out, it was the phase of like catching up on medical records. Like, they followed me through my residency. Like when I started out, the intern did all the medical records and stuff like that. Then they got more and more worried about it, and it kind of followed you up through your residency, and then you became an attending, and you became responsible for the medical records, and this followed me all the way up. But when I started out, sometimes you just have to dictate, op notes and things like that for your senior partner who didn't dictate the op note, 2 weeks ago. And I always used to put in, like, I would deliberately insert the sentence at the beginning. This is being dictated as a standard operation, and you would just dictate it in the most standard fashion because you don't know the details. You can't say something about the details. You can't even really say, like, what suture was used or anything like that because, there's a bunch of different possibilities, and it's worse to put something wrong in than to just be vague. It's better in that situation to be vague,
Absolutely. No, it's an interesting time, and diligence and attention to detail saves you in the AI world. Mm-hmm. And actually documenting what you did, what you saw accurately is a mitigating factor against lawyers that if there's a suit or something, they go after the weaker note, the person that's not documenting correctly, the person that's got 2 weeks behind all their charts. I mean, it's all time stamped. They can audit it, and then you can look really bad, on the stand in front of a jury, you can look bad that your pattern of behavior is
sloppy,
right?
Right.
So, it's a problem.
We should finish up in like 5 minutes or so. Let me get you a couple things I wanted to talk about. One, you were talking about the robotic, which you just touched on, how AI can assist in robotic surgery. And I also want you to go again. I've been thinking even more. You mentioned it this morning when we talked about your idea of the AI autopsy. I think that the more I thought about it, the better that sounds. It could bring autopsies back and get some, the way you were talking about, get some training for the residents too,
Sure. Now bringing let's just say bringing AI into the minimally invasive world, right? So minimally invasive that you and I would do a gallbladder, you can do all sorts of things. You can even do a Whipple minimally invasively. Right. So the use of the robot, one of the interesting applications is computer vision. So there are applications where while you're doing your laparoscopic cholecystectomy, you're able to have a mask over the monitor, where as you're moving around the gallbladder, you're moving around the common duct, there are structures that you have to avoid or be sensitive to. There's alerts and visual alerts and audio alerts that you're getting close. Mm-hmm. Be wary of the following structure. Mm-hmm. And those are nice aids to have for people that don't have a lot of expertise.
Well, the other thing with robotic too is I haven't done very little robotic. But I know one of the concerns is the loss of proprioception and everything, So like one of your alerts can just be you're pushing really hard on this thing. Now, when I saw Dr. Sofrolia, I went down when he was in Alabama. I think he's at NYU now, but he was like the maven of robotic lobectomies, lung lobectomies. And he had done, he had published like 1,300 or something by the time I went down there. He's done probably 3 times that by now. But he was skittish. You had to have a bedside assistant, and he was really, a little bit skittish about not how hard are we pushing on that? How's that feel? That's kind of one of the weaknesses of the robot, which could be helped by the AI.
Absolutely, haptic feedback. This aspect of the technology keeps improving. Yeah. And so robotics keeps evolving, and then applications that live around it, like computer vision, make it better and better. Mm-hmm. Unfortunately, surgical residents don't have the same open exposure and experience that you did in your training.
Oh, absolutely.
And it's a problem worldwide where the residency programs around the world, people want robots and they want, patients want to have them not be the person that a resident learns on, right? These are their issues. And
Dr. Cooley used to say a couple people had to die to train a cardiac surgeon,
how many residents do total gastrectomies because of a perforated ulcer or something? you're not doing it. You need a fellowship to do liver surgery,
Right.
hepatobiliary. So, the virtual autopsy, my initiative it's a precision medicine information system platform where we combine virtual autopsy with robotic biopsy. That's a very interesting dynamic where medical students and residents could engage with the robot to do biopsies. The person's deceased. It's not a med legal thing like it is when they're alive, right? It's a different engagement. And by the way, I think you learn anatomy a lot better when you can fly through a CAT scan and then physically go remove a cyst in the right lobe of the liver with your hands rather than looking at some animation. Okay, so what? Right. So that's going to be it's a company in my venture studio. It's one of my portfolio projects. And
you said I won a prize or something, right, in the contest?
We won first prize in the New Jersey New Business Model Innovation Competition in November. And when I see you, I'll bring my laptop, and I want to walk you through that deck. I think you'll find it intriguing.
Really good. Remember to bring the book so I can sign it for you too.
Oh, thank you so much.
And we're going to finish. Let me say one thing. You reminded me of again though. It's very interesting. I started surgical residency 73. Laparoscopic surgery, I took it at down in Marietta, Georgia, where Eddie Joe Reddick and those guys started it basically around 1990. And I started doing lap gallbladders. And, through the 90s, very quickly, the majority of gallbladders started getting done laparoscopically. And then laparoscopic surgery burgeoned, from there. But I was always way more comfortable open, even to the very end of my career. I was still more comfortable open, but I really would see in surgical residents that they were much more comfortable laparoscopically. And now I think maybe robotically, they got very uncomfortable when they actually had to make an incision. And I guess it's just, what you get used to, when you're trained.
Yeah, I mean, visualization is better with cameras, right? You get to see things. But again, by the way, I won't say who it was, but I was in my training. I had some interesting guys that trained us. We had an Italian surgeon. He had sleight of hand, like a magician. He could tie knots. Like, it was very strange how this guy's hands were so good. I had another surgeon, MIT Hopkins trained guy. He really couldn't tie knots too well. I mean, he memorized every book, but his hands were not the same. And that's the art, I guess, as you know, from doing cardiac surgery. Not everybody is equal, but they can be very smart, right? They can be really smart, but there's an art to it.
That's right. There's really two variables with surgery. Especially the one intelligence. You have to have intelligence to pick out the right patients and know what to do and all that. But the technical ability is another in many ways a completely different variable. And a lot of guys that are great, know tremendous in knowledge are not good technicians, and then sometimes vice versa. The one thing you're talking about tying knots, I don't know how it goes now with the robots, because this article I read a long time ago when I first started doing robotic, they were talking about robotic mitral valves. And the article, his point in the article, the worst part of the robotic mitral valve, mitral valve, you got to put in like 13, 15 stitches. So, and normally you put in one. Some people will run it and maybe only tie like 3 or 4 times. But most people put in, about 10, 12, 13 stitches and tie 10 or 12, 13 times. He said that the fastest anybody could tie robotically was something like 35, 40 seconds. Whereas, by hand, even the worst guy can do it in, 2 or 3 seconds.
Sure.
So that was a big problem. I mean, in terms of bypass, you're really adding bypass time and everything like that. I don't know if now, what I've seen in laparoscopic surgeries, they kind of are trying to get away from tying knots as much as possible and using those sutures that have little latches on them and things to get around from actually having to tie a knot. Yeah.
Yeah. I mean, when I was at Yale, we were very early in robotic surgery, and the surgeon that was training me, he actually had made very long Castroviejo drivers, really long ones. Yeah. And we were tying sutures at the end of this 1 foot long instrument by hand. It was very
laparoscopically or robotically.
No, laparoscopically by hand.
Yeah. Oh wow. Yeah. That's it.
And if you
laparoscopic is so hard to tie, to sew and tie, compared to robot, even to sew laparoscopically, because it's opposite. You're pivoting, through the abdominal wall, and every movement is opposite. Whereas a robot, it is more intuitive. It's a more natural.
It's an interesting space, but it's for residents. Every year they just do less open cases.
Right. Yeah.
And it's just the reality. So. Something to talk about maybe on another call, but I'm so excited about your book, and I think it's dead on center for what's needed now on the conversation, and certainly AI can bring a lot of value to your vision.
Well, definitely. I think we should wind this up. We don't want to bore people with going too long here, just talking about surgery, but. We will have another one. That's good, because I've already thought about 3 or 4 other things I want to ask you about, but wait for another day.
All right, Charles. See you soon.
See you.
Take care.
Bye-bye.